Good morning, dear professors and colleagues. Thank you, Dr. Muna, for the generous introduction. We will present different cases with hyponatremia, highlighting the red flags in every case. Let's start with case number 1. This is a male patient, 9-month-old. He presented to the emergency department at the age of 4 months for evaluation of severe dehydration, preceded with the vomiting, diarrhea, and poor feeding and severe hypotonia. This patient have a normal antenatal and natal history, but have a previous history of sibling death at the age of 3 months with a similar condition of gastroenteritis. On examination, the patient was shocked with a severe failure to thrive, hypotonic, no dysmorphic features, and normal male genital examination, but pigmented overlying skin of the scrotum, and normal other examination. We started to think about this patient as any general pediatrician. Do we have a patient with sepsis or organ failure, metabolic disorder? And we started the initial investigation. The CBC with differential was negative, CRP was negative, and venous blood gases revealed normal iron gap metabolic acidosis. Kidney function was normal, and the electrolytes revealed severe hyponatremia, hyperkalemia, and we have hypoglycemia. And so we have an infant with a severe hyperkalemia and hyponatremia. This is an algorithm for the differentiation of these cases. The first step, we have to check that this patient has a normal glomerular filtration rate, and to check that we have a full-term infant, not a premature, to exclude that tubular interstitial tubulopathy that a premature has. Then, if we confirm that, we started the sophisticated investigation of the endocrine precursors to differentiate if we have hypocorticism or hypoadrenalism. So we have to check for the endocrine assessment, the cortisol level 17, hydroxyprogesterone, and the renin and aldosterone, and according to the results of this investigation, we will fit the diagnosis of our patient. So what we have a red flag in this child, we have a severe failure to thrive, history of sibling death, pigmented genital skin, and hypoglycemia. We started management of this patient with a bolus rehydration for the chalk therapy, IV dextrose 10% for correction of hypoglycemia, and the anti-hyperkalemic measure in the form of IV calcium for the cardiac protection, and sodium bicarbonate for the shift of the potassium from extracellular side to intracellular side, and we did withdrawal of the steroid precursors, and we started a stress dose of bolus hydrocortisone. And the investigation revealed that our patient had primary hypocorticism and hypoaldosteronism and normal other adrenal precursors. So back to our algorithm. So we have a patient with a mineralocorticoid deficiency and hypocorticism, but we have a normal 17 hydroxyprogesterone, so we exclude the most common cause of adrenal insufficiency at that age, which is congenital adrenal hyperplasia, and we have the more rare form of congenital adrenal hypoplasia. The patient treated with hydrocortisone and flavocortisone and oral saline therapy. What about the adrenal hypoplasia? It's a very rare form of congenital adrenal disorder. It's either X-linked or autosomal recessive disorder, and it may be associated later on with hypogonadotrophic hypogonadism. And for the second case, that we have a 3-month-old male infant. He presented with the same picture described here at the age of 4 weeks and admitted at NICU with a failure to thrive, sleepless, refusal of feeding, and interrupted urine stream. He has normal antenatal and natal history with normal birth weight. On examination, the infant had slightly hypertension, tachycardia, tachypnea, and fevers with moderate dehydration, hypotonia, and normal genital examination with no pigmentation of the overlying scrotal skin. The same way of thinking, the CBC with differential revealed cytosis, pandemia, CRP was negative, and normal iron gap metabolic acidosis also. The kidney function revealed slightly elevated UN, and the creatinine is slightly elevated for his age. We have a pre-renal element in that infant, and we have also hyponatremia, hypokalemia, and normal blood glucose. We started management of this child with resuscitation by the intravenous fluid to bolus therapy, and the ECG was done to exclude any ECG changes and further management of hyperkalemia, and the initial empirical antibiotic therapy was started, and IV bolus stress dose of hydrocortisone was started. But surprisingly, this child was corrected after 6 hours for the hyponatremia and after 2 hours of hyperkalemia after initiation of the fluid therapy. The same investigation was done for that child for the adrenal precursors, but the further hydrocortisone doses for the maintenance was withheld till the investigation was revealed. This investigation revealed normal cortisol level, normal adrenal precursors, but we have elevated aldosterone level and plasma renin activity. And according to that algorithm, we are in the part of the algorithm that we have a defect in the mineralocorticoid, either action or secretion, but we have a normal cortisol axis. So we are facing a condition of hypoaldosteronism, either primary or secondary. What was alarming is that child interrupted urine stream in the mother history, recurrent attacks of rapid correction of the IV fluid, the sepsis profile was positive, and the normal blood glucose. This child was, his ultrasound revealed enlarged bilateral hyporetronephrosis, nephrosis, and his urine culture was positive for E. coli. And probably the diagnosis of this infant was secondary to hypoaldosteronism. What about this disorder? It's unresponsiveness to mineralocorticoid. It's either primary or secondary, and the secondary usually to urinary tract malformation or urinary tract infection. And lastly, this child, and the last case is a female child. Now she's 4 years old. She presented at the meeting department at our Outreach Hospital at the age of 7 days for evaluation of severe dehydration secondary to persistent vomiting, jaundice, and poor feeding, and severe hypotonia, and suddenly the patient had cardiac arrest. On examination and on the antenatal and the natal history was unrelevant. On examination of this child on admission, she was severely dehydrated, hypotonic, no dysmorphic feature, and normal genital examination and normal other system examination. Investigation revealed that we have normal CBC, negative CRP, and venous blood gases had normal iron gap metabolic acidosis, and the kidney function was totally normal, and the patient has hyponatremia, hyperkalemia, and normal blood gases. The patient was started with resuscitation and the anti-hyperkalemic measure, but she was resistant to all modality till we reached peritoneal dialysis. The precursors of this infant revealed that we have normal cortisol level, normal adrenal precursors, but we have a very elevated level of aldosterone and the plasma renin activity. And back to our algorithm, we are again here in the part of defect in the aldosterone action. But here, either we have a systemic or renal involvement of the type of pseudo-hypoaldosteronism. What are the red flags here in our patient? We have a very early onset of symptoms, but very severe symptoms with severe resistant hyperkalemia, severe hypovolemia, and normal serum blood glucose. So we probably have a pseudo-hypoaldosteronism type 1, treated with just oral saline, potassium chelation therapy, and oral sodium bicarbonate. What about this problem? This is unresponsiveness to mineralocorticoid, either on the renal level or multiple target organ defect. It's heterogeneous form, but the systemic form is very aggressive. And my take-home message: any sick infant, please do electrolyte and the blood glucose, and constipation of hyponatremia, hyperkalemia, normal iron gap. It's disruption of the secretion or action of aldosterone, not hydrocortisone. Not every patient with hyponatremia and hyperkalemia need hydrocortisone therapy. And lastly, أي مناسبة نبقى فيها أساتذة لازم نتذكر أستاذتنا الغالية الأستاذة الدكتورة عزيز غالي رحمة الله عليها. Thank you so much. say